So thank you very much, everyone, for your continued interest in our program. Today, we're very fortunate to have Professor Liz Soilleux, who's a consultant pathologist, hematopathologist, and academic at University of Cambridge. I've known Liz for many years, and I've prevailed on her for many favours, and she's always graciously accepted them. She is an international expert in lymphoma. She does an awful lot of work on celiac disease and is developing AI tools to help diagnose celiac disease. Her teaching and both academic and clinical record is too long to waste her time on me going through. I'm delighted to have talk today on T-cell lymphomas. This is a difficult area. They're relatively uncommon, but of course it's important to try and recognize them. I'm sure that Professor Soilleux will give us a very clear introduction that even I will be able to understand. So without further ado, I will pass over to yourself, Liz. Thank you very much.
Great. Well, thank you, Richard, for that exceptionally generous introduction. I just won't fail in terms of sharing my screen now after several challenges a little while ago. Here we go. So hopefully you can see that screen. And if we go onto the right option, if that doesn't look full screen to you, please say something. So yeah, my brief today, which was rather at my request, is to talk about T-cell lymphomas, and you'll see why I'm interested in these in a minute. This is going to be in 3 sections. The first section is the principles of diagnosis. The second section is going to be about systemic T-cell lymphomas, and the third section is cutaneous T-cell lymphomas. Some of it might be fairly rapid fire, so sorry if it's too fast, but there's lots of interesting stuff to say. That's the reason. So to understand anything about T-cell lymphomas, you need to know what a T-cell is, and I'm sure this audience knows that. The key immunostains that we need to think about with respect to T-cells are CD3, really, which identifies something as a T-cell. And then, of course, we've got TD2, which is quite a common T-cell marker, and then CD5 and 7 less so. Most T-cells have the alpha-beta T-cell receptor, which currently is relatively difficult to detect in tissue sections, but we'll come on to that in a minute. And more of them are CD4 than CD8 positive. Most alpha-beta T-cells are in the lymphoid organs, while most gamma-delta T-cells, the minor type of T-cell, are at mucocutaneous barriers, and that actually rather explains the pattern of lymphomas that we see as well. I'm hoping you can see my pointer, but if you can't, can someone let me know that too? So in terms of T-cell lymphomas, what matters, you need to recognize them. You have to be completely certain that the T-cells are malignant, which is not always straightforward. And then you want to subtype them. And the sites are predictable from the sites at which I told you find T-cells. So when we think about the diagnostic process, we can divide it into looking at the morphology, which is sometimes helpful, both in terms of the architecture, how the cells are arranged with respect to each other, and also their cytology in terms of what they actually look like. There's the immunophenotype, and then we might want to prove that the T-cells are clonal. It's quite a complex DNA-based multiplexed PCR test. We actually have been developing an easier immunohistochemical method for T-cell clonality. It's a surrogate for clonality, very much like kappa and lambda for B cells, which I'm going to show you a little bit of. If you're interested in collaborating on developing this test further, oh, I see I've mistyped my email address. My email address is typed correctly later on, but do get in touch if you think you might be interested. Just to remind you, we have to think about a variety of simple differential diagnoses for T-cell lymphomas, like florid reactive lymph nodes, and of course you can see those in all sorts of infective processes and many others. And I think everybody will be familiar with florid reactive nodes in that you've got these huge B-cell follicles, often which are CD20 positive, surrounded by CD3 positive T-cells, with some T-cells also sitting within the follicles. CD79A is obviously another B-cell marker. I think most of you will be familiar with normal follicles, which are CD10 positive and BCL2 negative if they're secondary B cell follicles, and also express BCL6 with a high proliferation index. But of course, the key thing is in these T cell areas, the proliferation index should be quite a lot lower and hopefully not more than about 5 to 10%. You can do kappa and lambda immunohistochemistry or in situ hybridization in benign nodes, which can sometimes be helpful. Probably one of the mimics you do need to think more about for T cell lymphoma is actually dermatopathic lymphadenopathy, where the paracortex of the lymph node dominates the node and there aren't so many B cell follicles. There are abundant CD1A positive Langerhans cells, and there's often pigment in cortical or paracortical macrophages, and there are lots of high endothelial venules. So here you can see those high endothelial venules in a very reactive dermatopathic situation. And these pale cells are the CD1A positive cells that turn out to be Langerhans cells, while you've got CD3 positive T cells almost everywhere and quite small primary B cell follicles. So that's probably one of the key mimics actually for T cell lymphoma, and probably one of the conditions we worry most about. So I've said that the T cells in T cell lymphoma can be normal, but they can also show some variation in size and shape, but so can activated benign T cells, so do be careful. But sometimes the morphology is obvious and you've got big pleomorphic cells, which we'll come across in a minute. The immunophenotype can be normal, which makes it difficult to diagnose a T cell lymphoma, may be aberrant, and can vary across the T cell proliferation. So I'm going to show you two of my secret signs that something's a T cell lymphoma, which actually don't really exist in the textbooks. One of those signs, which I find extremely helpful, is just simply when you look at something like CD3, and you see quite a lot of variation in the size and the shape of the T cells and the level of CD3 staining. And that to me is a pointer to look harder for T cell lymphoma. The other thing I find useful when looking for T cell lymphoma is T cells that just have a little bit of CD30 positivity. Some T cells have lots, and we'll come on to those in a minute. The high grade or anaplastic large cell lymphomas have lots of CD30, but the other T cell lymphomas don't. But you often see this spectrum of CD30 expression from very weak up to strong. And that makes me sit up and think about whether something might be a lymphoma. I mentioned that when you've thought about morphology and immunophenotype, you might want to think about clonality and indeed other molecular studies like FISH, which can be useful for anaplastic large cell lymphoma. And so the key thing you might want to think about is doing a PCR-based clonality test if it's available to you. And there are quite a lot of conditions where we find that we really can't make the decision without doing such a test. Although once long ago, at the beginning of my career, we somehow managed, and goodness knows how many we got wrong. You have to be careful with clonality testing because you can see something that looks a bit like clonality in skin and also in the small intestine in celiac disease, which is obviously more common in northwestern Europe than it is elsewhere. And also you can see something that might look as if it's clonal if the DNA that you've managed to amplify has come from a very small number of T cells, either because there weren't many T cells in the specimen to start with, or because the quality of the DNA was poor and not very much of it amplified. There are people who use clonality to say whether there's a T or a B cell receptor rearrangement as a method for assigning lineage. And most of the time, that's perfectly correct. But sometimes the lineage you assign on that basis turns out to be different from the lineage you would assign from other phenotypic features. So a little bit more on T cell clonality. For the multiplex PCR assay, we would normally run 3 multiplex PCR tubes from the patient's DNA from the suspected lymphoma sample, and 1 TCR gamma locus tube, and occasionally we run a TCR delta locus tube as well. I'll show you in a minute how this test works, but essentially we're looking at the length of the PCR products, which is on this axis here, and the amount of product, which is on this axis here. And if you have a variation in length with a sort of Gaussian distribution like this, the sample's generally benign. Whereas if you have a single peak, the sample is generally lymphoma. The old-fashioned method was something called heteroduplex analysis, which was done on a gel. It's much more difficult to interpret, except under very specific circumstances. During this talk, I'll also show you that we've made a nice pair of antibodies, which are like kappa and lambda for T-cell lymphomas. So this is a T-cell lymphoma that's TCR beta 2 in type, which I'll show you in a minute how that works. And it's very clearly negative for 1 and positive for 2. And that's just higher power of the same. This immunohistochemical test could well be something that could be used very simply, cheaply, and easily instead of T-cell clonality. So if that's not available to you and you are interested in maybe testing out some antibody, please get in touch and we can probably send you some. So how does clonality work? Many of you will have learnt at some stage in your career about how a T-cell receptor is made, and it's made from putting together V, D, and J segments if it's a TCR beta receptor, for example. What we do ultimately is we're doing a PCR reaction that runs across the combined V, D, and J segments here, and we're looking at the length of the PCR product we get. If the T cells are different and not clonal, we get loads of different lengths of product, which is what I showed you here. Whereas if they're the same, we get something that looks like this, one single peak, because they're a clone. So that's one way of looking at clonality. However, we are aware that the T cell receptor beta, a bit like Ig heavy chain, can use the C beta 1 or 2 segment here. And actually you can differentially detect whether the T cells have TCR beta 1 or TCR beta 2 with the antibodies that I've shown you briefly. And that's a simpler way of looking for clonality than doing the PCR testing, although there will still be cases that will require PCR testing even after that. Okay, so just to show you in real life what the clonality testing results look like when you're not sure if something's lymphoma. This is an example. These are duplicate samples from a patient that have had the PCR test, and this is a polyclonal control that's known to be polyclonal. This is the size of the DNA product and the amount of product. And what you can see is the polyclonal control is a reasonable Gaussian distribution, whereas there's this huge peak in the patient sample, and that indicates it's clonal. But as I've said, we do have a pair of antibodies which we've been working up and are hoping will be available for clinical practice in early 2027, although they can be used on an informal basis before that. And you can see here, this is just some benign cases of lymph node tonsil. This is with one of the TCR beta antibodies, this is the other one, and around about half of the T cells are positive for TCR beta 1 and half for TCR beta 2. However, when we look at T cell lymphomas, this is TCR beta 1 over here and TCR beta 2 over here. These three lymphomas are TCR beta 1 restricted with very few TCR beta 2 positive cells, and this lymphoma here is TCR beta 2 restricted. So you can see this works quite nicely in at least a reasonable number of lymphoma cases, and it may be of interest. So having shown you how you might go about diagnosing T-cell lymphoma, I'm going to run through the key subtypes and how you subtype T-cell lymphoma into these various types. We'll start with the systemic T-cell lymphomas and then move on to the cutaneous ones. I'm using the subtypes as defined in the 5th edition of the WHO classification. I haven't gone through every single subtype that's in here. I've tried to do the more common ones on the basis that some of the other things I think I virtually never see, and it depends a bit on where you work, but you're unlikely to see many of them either. So we'll start off with T lymphoblastic leukemia or lymphoma, or acute lymphoblastic leukemia of T-cell type, ALL. Just to remind anyone who's not sure about nomenclature, lymphomas give you masses, while a leukemia involves blood and bone marrow, and the designation of leukemia essentially trumps lymphoma. So if someone has masses but they've got a blood or bone marrow phase, then essentially it's a leukemia. So lymphoblastic leukemia or lymphoblastic lymphoma is a T-cell neoplasm. It has to have CD3 on it to prove it's T-cell. It often has other T-cell markers, and it must, or virtually must, always express TDT, and usually CD34 and CD1A, but not always. The vast majority of them are CD4 positive and 8 positive. And you can see this is taking you through the stages of development of a thymocyte. And essentially, a lymphoblastic leukemia or lymphoma recapitulates one of these stages of development, and that will explain exactly what it expresses on its surface. So I'm just going to show you what normal thymic structure looks like. You've got the cortex, which is darker, and the medulla, which is lighter, with Hassel's corpuscles. In general, lymphoblastic lymphomas and leukemias look like the cortical thymocytes, but sometimes they look a bit more like the ones we see in the medulla. So here's an example of lymphoblastic lymphoma. You can see big blast-like cells, and I've told you the phenotype. The critical thing is CD3 and TDT, and these other markers are usually present but not essential. And this is just showing a section of thymoma, which has quite a lot of thymocytes in it, which aren't dissimilar to this. If you're wondering whether it's a T lymphoblastic lymphoma rather than normal thymus or a thymoma, staining for cytokeratin is often really helpful, because if it's a thymoma, there's lots of cytokeratin positivity. If it's a lymphoblastic leukemia, then there'll be or lymphoblastic lymphoma rather, there'll be very little cytokeratin staining, because it will have obliterated most of the thymus. And if it's not in the thymus, then you won't have any cytokeratin unless it's in a non-lymphoid site. That's just an example of some of the other stains, which reminds me to say that PAX5 is the B-cell marker that you need to be clear is negative, unless it's something that's of ambiguous lineage. Okay, so moving on to other things that, again, straddle this sort of solid liquid phase. T-cell large granular lymphocytic leukemia. It's quite uncommon, but you see it particularly in elderly males who tend to have neutropenia, splenomegaly, and features of rheumatoid arthritis. You get a very brisk infiltrate of small T cells in the bone marrow, usually, sometimes in clusters, and sometimes associated with B cells as well. There's a very significant increase in CD8 positive T cells, and usually the marrow shows impaired myeloid maturation because of the T cells having an effect on the myeloid lineage. They're generally TCR beta positive, and they sometimes have CD57, well, quite often have CD57 and various cytotoxic markers. So here's an example. This marrow contains lots and lots of cells of T-cell large granular lymphocytic leukemia. There's some examples here, but you can also just see the little cells sitting here. And the fact they're in a line is relevant, which we'll come on to in a moment. So you can see there are B cells associated with them, and there are nodules of T cells which are predominantly CD8 positive. What's really interesting is that when you get any condition that's circulating in the blood and also involving the marrow, it often sits in the sinusoids. And here you can see the T cells lined up beautifully within the sinusoids because they are also circulating in blood. So this is often a diagnosis that's made on peripheral blood using flow cytometry, but we do sometimes also see it in bone marrow samples. And talking of things that like sitting in sinusoids, hepatosplenic T-cell lymphoma also does that, and it tends to circulate in the blood as well. This is an example of hepatosplenic T-cell lymphoma in the liver. And you can see TIA1, which is one of the markers of cytotoxic T cells, is very positive on those cells that are sitting in lines, again, because they're sitting in sinusoids. The phenotype is that of a generally a gamma delta T cell with a lot of cytotoxic markers, but some of them are alpha beta in type. They're very rare, and I've seen a very small number in my career. Moving on to something more common, the T follicular helper cell lymphomas have been reclassified fairly recently, so I'm just going to run through them. In my day, when I started hematopathology, all of these were simply called angioimmunoblastic T-cell lymphomas, but things have changed in the last couple of editions of the World Health Organization classification. So these are CD4 positive T-cell neoplasms, which sometimes lose some of their other antigens. But critically, they express markers of what's called follicular helper phenotype, like CD10, BCL6, and PD1, or CXCL13. They don't have a lot of CD30 on them, and the cells are relatively small, so it's often quite difficult to be certain that they're not just benign reactive T cells. They also have a lot of CD8 T cells mixed with them, which is confusing. One of the things to know about the T follicular helper cell lymphomas is that they prevent the individual being able to control Epstein-Barr virus infection, and quite often you see Epstein-Barr virus positive B cell blasts sitting in the tissue associated with the T cell lymphoma. Occasionally you actually get a full-blown high-grade B cell lymphoma that's a consequence of having a T follicular helper cell lymphoma, so it's important to look out for that. The three types of T follicular helper cell lymphoma are angioimmunoblastic, where you've got these high endothelial venules, which you can see. I've got some examples in a minute. You can genuinely see them without immunostaining, but they're CD34 positive high endothelial venules. And you have follicular dendritic cells that wrap themselves around these venules. Meanwhile, the follicular type looks a bit like progressive transformation of germinal centers or even dermatopathic lymphadenopathy. And then anything that doesn't fit these patterns is put into a not otherwise specified category. So this is an angioimmunoblastic type, and you can see the blood vessels here. There are lots and lots of vessels running through this specimen. And when you stain with CD34, you can see that clearly here. That shows up the vessels. And the CD21 stain shows you the follicular dendritic cells that wrap around the vessels. The other things to note, as I've mentioned, is that you do get expression of these follicular helper markers, including CD10 on some of the T cells, and that these are mainly CD4 positive. Well, they are CD4 positive, but you do have admixed CD8 positive cells as well. This particular example does have a small number of Epstein-Barr virus-driven B cells proliferating within it, some of them quite large. And that's obviously something to look out for in case you do get a secondary B cell lymphoma developing. The proliferation index MIB1, which is pretty much the same as Chi67, is pretty variable between cases. And you can see here it's not all that high, but it's probably high enough to make you stop and think about whether those T cells are benign. Okay, so now another fairly straightforward and reasonably common type of T-cell lymphoma, anaplastic large cell lymphoma. And these are obvious. You don't need clonality studies or anything else to be sure that these are malignant, because you've got very large pleomorphic or anaplastic cells. Some of them are called hallmark cells. They're a kind of horseshoe shape, so a C shape. And sometimes they look syncytial, as if they are forming a solid piece of tissue. In general, they're CD30 positive, but they may not have any other T-cell antigens remaining, which can make it really difficult to diagnose them. Some of them, however, have CD4, and quite a lot of them have CD25, and possibly cytotoxic markers, and EMA sometimes. The ones that occur in younger people with a better prognosis tend to express anaplastic lymphoma kinase, or ALK, and have a translocation, often with NPM1 to ALK, but there are other translocations too, which will give a better prognosis. And you can see the ALK1 positivity on immunostaining, and and you can use fluorescence in situ hybridization to look for the translocation. The ones that are out negative, unfortunately, have a much poorer prognosis and tend to occur in older people. While I've said you should not do clonality PCR to determine whether it's a B or T cell lineage, sometimes if you've got a CD30 positive tumour and you're thinking about things like germ cell tumours as well, doing PCR and showing a rearranged T cell receptor can be helpful in demonstrating that at least this is lymphoid and not some other type of tumour. So here's an example. This is very obvious. You've got these highly pleomorphic cells, and you can see that because they're T cells, they're actually respecting the B cell follicles in this case and sitting in the normal T cell area in the paracortex. So they don't necessarily wipe out everything else in the lymph node. Here's the CD30 stain. It's very strong. And in this particular case, there was ALK1 positivity, so there was a translocation, while there was significant loss of other T cell markers and a very high proliferation index. So that's a fairly characteristic anaplastic large cell lymphoma. Now, something we see really pretty rarely in the UK is adult T cell leukemia stroke lymphoma, but some of you may work in settings where that's more common than it is around here. This is a mature T cell neoplasm with a variety of presentations, which I think is what makes it so difficult. It can present with lymphadenopathy, skin lesions, hepatosplenomegaly, eosinophilia, and actually I should have added bone lesions as well. So it's that lymphoma that you need to think of when the presentation doesn't make sense. The key thing actually is that the patient either has antibody against HTLV1 or has integrated HTLV1 DNA in the lymphoma. I think we normally just go with the antibody. It tends to retain most of its T cell antigens and have CD25 expression, and they're normally CD4 positive rather than 8 positive. With some CD30, that's quite variable. So there are a variety of other T cell lymphomas this can mimic, and it's really the HTLV1 positivity that will tip you to calling it ATLL rather than anything else. Here's a really nice example of a lymph node that's full of ATLL. And you can see you've got some fairly big pleomorphic cells in this particular example over here, while this example that's had immunostaining has got smaller but slightly pleomorphic cells. So it's quite a variable presentation overall in terms of the site, clinical presentation, and even the cell morphology. So another thing I did want to remember to mention is Epstein-Barr virus in T cells. Many of you will be very familiar with Epstein-Barr virus driving B cell neoplasms, things like Burkitt's obviously, but actually occasionally T cells do get infected with Epstein-Barr virus. And I was actually reminded of that on yesterday, when I had to present a case at one of our multidisciplinary meetings, which was a T cell lymphoma being driven by Epstein-Barr virus, which incidentally didn't actually fit into the classification that I'm about to present to you. So we basically got EBV positive nodal T or NK cell lymphoma, and also an extranodal form of the same thing, which tends to be found in the nose. The exact nomenclature has changed slightly again in the 5th edition of the WHO classification, but fortunately nothing much else about this condition has changed. So morphologically, the key thing is that these EBV positive T cells are centered on blood vessels. They're angiocentric and they are angiodestructive. So they destroy the blood vessels. There's blood all over the place. And there are also areas of necrosis, because not only are you causing the blood vessels to leak, but you're also preventing them supplying blood to parts of the tumor and adjacent tissue. The cytological features of this are incredibly variable, and that's true for many things that EBV drives, as you will know. More often they've got an NK cell phenotype, but they could also have a cytotoxic T cell phenotype. The critical thing is that they've got EBV in them, and they've got some kind of T cell or NK cell lineage markers. If you do flow cytometry on them, which we often don't because they're usually in solid specimens, they have no CD3 on their surface, but it's all cytoplasmic. From our point of view as pathologists, they look CD3 positive, but if somebody looked at them with flow cytometry, they'd assume they were negative. And so here are some examples of the H&E appearances, and you can see there's lots of hemorrhage here and also necrotic tissue because of the angiodestructive nature. This is difficult to see much of the cell morphology on, but you can perhaps see it better here on the granzyme B when you've got really variable cell size and shape, and also on the EBV stain when again you can see the nuclei vary quite markedly. Okay, so we're getting into the small print now for the last few systemic lymphomas before we move on to the cutaneous ones. And in the UK, celiac disease, which is a sensitivity to gluten that's found in wheat, rye, barley, and a related protein in oats. Celiac disease is quite common. It's about 1% or maybe even as high as 3% of our population. I think in other parts of the world that really isn't the case, and so you may see far less of this condition, and we only see a very small number of cases per year locally. So we will tend to see more enteropathy-associated T-cell lymphoma that's celiac disease associated. In other parts of the world, particularly the Far East, this other T-cell lymphoma, monomorphic epitheliotropic intestinal T-cell lymphoma, or METL, is much more common. Both of them are masses that form mainly in the small intestine, but they can also involve stomach or large intestine. They can also involve other sites, including lymph nodes, and they both comprise CD3 positive, CD7 positive, but CD5 negative T cells, which have expression of some cytotoxic molecules. The one that occurs in celiac disease often has large CD30 positive cells and is very obviously malignant, and they're CD56 negative, so they have no natural killer cell phenotype. Whereas the one that tends to occur without celiac disease tends to have smaller cells, which retain CD8 expression, while the celiac-associated one has neither CD4 nor CD8. And the monomorphic one tends to have CD56, which is an NK cell marker. So here's an example of an intestine. I think it was probably taken out for either obstruction or perforation. And I think this is trying to show a necrotic area here with perforation, which is often the presentation of these lymphomas. In this case, you can see there's a huge mass, which was probably completely obstructing the lumen. And more importantly, you've got an area here of necrosis, which has presumably led to perforation. So the celiac-associated, enteropathy-associated T-cell lymphoma, as I've said, often has large cells, which tend to be CD30 positive, though the CD30 is this one, it's quite weak. And when you look in the epithelium, you have significant numbers of intraepithelial lymphocytes, which are characteristic of celiac disease. The monomorphic version, which is not celiac associated, sometimes does have intraepithelial lymphocytes. That's a bit more variable. But in general, the cytology is a bit smaller. And as I've said, they're CD30 negative. So there you are. There's a bit of a comparison. But to be honest, you need to think about the clinical context as well as just the immunohistochemical markers. As with everything in the WHO classification, you always need a dustbin category. And so the dustbin category that anything left goes into is peripheral T-cell lymphoma NOS. It is a diagnosis of exclusion for mature T-cell lymphomas that don't fit anything else, and more of them are CD4 than CD8 positive because more T cells are CD4 than CD8 positive. If they're strongly CD30 positive and large, then it's anaplastic large cell lymphoma. but anything that is left can go into this category. And then one other uncommon condition is T prolymphocytic leukemia. It's generally a leukemic condition that's diagnosed at least locally on flow cytometry, but you do occasionally stumble across it in tissue, and you have to think about it so that you make the right diagnosis. You've got small to medium, fairly monomorphic cells, as you can see here. They've retained many of their T cell markers, but quite often they have both CD4 and CD8 without expressing TDT, which distinguishes them from lymphoblastic lymphoma. And so it's important to think about that because the treatment is different from many of the other T cell lymphomas. So finally, we're going to look at some examples of cutaneous T cell lymphomas. These are difficult, but there are some principles that are important to remember. And if you remember only one thing, remembering this slide with the principles of cutaneous T cell lymphoma is probably a good thing to remember. Staging is really important in deciding whether something is actually a cutaneous T cell lymphoma. So for the classification, just saying quite simply, is this cutaneous or systemic? You actually need to know whether this is all over the place in the patient or just in the skin. And that determines the treatment. And the treatment is radically different if it's just in the skin. As I've said here, you tend to just treat with radiotherapy if it's confined to the skin, or sometimes even just steroid creams. Whereas if you've got a systemic T cell lymphoma, then obviously you need chemotherapy. And that can occur either because a cutaneous T cell lymphoma has gone on to become systemic, or because the lymphoma was always systemic and has got secondary involvement of the skin. So certainly locally, mycosis fungoides is the most common cutaneous T cell lymphoma that we see. That is an unusual condition, which we'll look at the histology of in a moment, but it has three clinical phases. There's a patch phase, and in the patch phase, where it really is very flat and you can't really feel it, but you can see a red patch, you've got a band-like infiltrate of lymphocytes just at the dermoepidermal junction. When you get a plaque phase, you've got more epidermotropism, so more of those lymphocytes are getting into the epidermis, and you've got a much thicker band of lymphocytes. They may have something called Portrier microabscesses, where you have groups of T cells sitting in the epidermis. By the time you get to tumour phase of mycosis fungoides, there's often no remaining epidermotropism, so you don't know that it started out as mycosis fungoides, which can make classification difficult. More of the cells may be medium or large in size, and there's more CD30 expression, or cells that are so-called cerebriform, that's sort of brain-shaped, which means they've got a wiggly edge, or blast-like cells. But if you get more than 25% of the cells looking large, that actually counts as transformation of mycosis fungoides to anaplastic large cell lymphoma. So this is the patch stage of mycosis fungoides. Here you've got the epidermis with a Portrier's microabscess, and you've got a sort of band-like superficial dermal infiltrate of lymphocytes with some histiocytes. Normally in the skin, most of the T cells will be CD8 T cells. So if you start seeing a preponderance of CD4 positive T cells, that can be very helpful. There's usually no particular antigen loss in mycosis fungoides, and certainly in our centre, this normally ends up requiring clonality testing in order to prove that this is actually a T cell neoplasm and not eczema or psoriasis. We have had some considerable luck with our antibodies looking at this condition, and this is an example of some epidermotropic T cells. These ones are largely TCR beta 1 negative, but TCR beta 2 positive. And so you can see you've got a TCR beta 2 restricted population of T cells in mycosis fungoides. And this actually, in this particular case, could act as a surrogate for clonality. And again, if you're interested in getting involved and having some antibody to try, please do get in touch. The other thing to remember to talk about is follicular tropic mycosis fungoides. And I say this because it's a sort of thing where people who haven't seen lots of cases of mycosis fungoides sometimes get this wrong, because they look at the surface and say there's no epidermotropism, this is not a T-cell lymphoma. But often it's not epidermotropic if it's follicular tropic, and that can be one of the problems. So I'll show you some examples of follicular tropic mycosis fungoides. I've said most of the things on this slide, except to say that you get what's called mucinous degeneration of the hair follicles. So if you stain with an Alcian blue stain, you can see Alcian blue positive substances accumulating in those hair follicle cells, and that's because of the damage to the cells by the T cells. This has a poorer prognosis in other forms of mycosis fungoides. I'm assuming that that's genuine, but it may actually be because people miss it. So you can see here, actually this one still has some epidermotropism, but a lot of cases do not. There is epidermotropism here, but the main lymphocytic infiltrate is down the follicles here. And when you look at this follicle, for example, you've got lots and lots and lots of T cells chipping away at the edges of the follicle there. They are CD3 positive, and actually, again, here's the follicle, and you've got all these CD3 positive T cells that have wandered in. The edge of the follicle's right over here. So there are lots and lots of T cells sitting within it. And you can see here there's a massive preponderance of CD4 over CD8 T cells, which is back to front for skin. It should be more CD8s in the skin. There is some loss of CD5 in this particular case, but there often isn't. And there's a little bit of CD30. Remember my secret sign for T-cell lymphomas, where you've got a variable level of CD30 from very, very weak to quite strong on a small to reasonable proportion of the T cells. Obviously, if you've got 25% large cells with CD30 on here, then that would count as transformation. But in this case, it hasn't transformed. So I'm going to show you an example of a fairly challenging cutaneous case. I'm going to tell you the answer of this one at the end. So this is from a 63-year-old lady with erythematous itchy papules on the face, thought to be perhaps rosacea or contact dermatitis, possibly sarcoidosis, or possibly follicular tropic mycosis fungoides. So there's a biopsy from the face. And you can see, the first thing you can see here is we've got what's called a Grentz zone or border zone beneath the epidermis. So the T lymphocytes are deep to this dermoepidermal junction, but there are an awful lot of lymphocytes. And when we look at them in detail, those lymphocytes are big and pleomorphic. They're not small. You've got some nice little ones which are doubtless reactive here for comparison purposes, but these are big. And there's another example of them being big. Here's a follicle. They're not attacking this follicle. They're just respecting its boundaries. So it's neither epidermotropic, you can see here, the epidermis is completely spared, nor follicular tropic. But it's got big cells. There are a few B cells there, which I'm not going to show you, but the vast majority of these cells are actually CD3 positive. And most of them, at least 75% in this particular case, are CD30 positive. And there's a little bit of EMA expression on some of those cells. They also were positive for the various cytotoxic molecules like TIA1, granzyme B, and perforin. They're negative for ALK1, but any time you see a population of large T cells, particularly if they're CD30 positive, it's important to do an ALK stain, because they may be the good prognosis ALK1 positive variant of anaplastic large cell lymphoma, but this is not that. These have CD4 on their surface, and only the infiltrating T cells are CD8 positive. They've retained CD2 and CD5, and probably not CD7, but they're positive for CD45 and CD43. So what is this? And hopefully, if you've been following along, you've had a chance to have a bit of a think. So this is something in the spectrum of CD30 positive cutaneous lymphoproliferative disorders, or CD30 positive cutaneous T-cell lymphoproliferative disorders, I should say. And they're jolly hard to differentiate. So you're going to need clinical information to get the right classification here, because if it comes and goes, it's lymphomatoid papulosis. Let me get my words out. If it is permanent, it's probably anaplastic large cell lymphoma ALK negative, but it could be transformed mycosis fungoides. And so you need staging and more information to work out what's going on here. Is it here all the time? Does it come and go? Does the patient have lymphadenopathy? So is it systemic? And so on. You can't do this on your own. So all you can do is write a report that gives them the options. I have to say that looking at this case, because it retains CD3 and CD4 and a lot of T-cell antigens, I suspect this is transformed mycosis fungoides. But one really does need this additional information to be certain. So this is my flowchart for sorting out cutaneous CD30 positive lymphoproliferative disorders. Question 1, is it epidermotropic? If it is, then it's transformed mycosis fungoides. If it's not, and it is permanent, doesn't come and go, then the question is, have they had mycosis fungoides? If they have, then it's probably transformed mycosis fungoides. If they haven't, it's probably anaplastic large cell lymphoma. If it's ALK positive, then it's an ALK positive anaplastic large cell lymphoma, and those are pretty much always systemic and not primary cutaneous. If it's ALK negative, which the bulk are, then the question is, does the patient have evidence of this disease anywhere else? And if the answer is no, then it's primary cutaneous anaplastic large cell lymphoma. And if radiologically it is systemic, then it's an ALK negative anaplastic large cell lymphoma that's systemic. And then finally, if it's not epidermotropic and not permanent because it comes and goes, then we're going down this route here, and it's best regarded as lymphomatoid papulosis. There's a whole load of different subtypes of this thing these days. This one I think would be type C, because it's most like anaplastic large cell lymphoma. But as you can see, there's a whole load of different types that are Hodgkin-like, mycosis fungoides-like, epidermotropic CD8 positive-like, and angiodestructive, or angiocentric and angiodestructive CD8 positive. I've personally never seen either of these two types, or type A. I've only ever seen types B and C. So there's a summary there of lymphomatoid papulosis. It's chronic, recurrent, and it's a self-healing skin disorder in which the lesions contain large atypical cells and an inflammatory background. If you do clonality studies on this, they are clonal, so they are neoplastic, but they don't always stay. Generally, eventually the patient develops a lymphoma that's full-blown, and this is just an early phase of it. I've mentioned the transformation of mycosis fungoides. That's just here for completeness. It needs to have more than 25% of its cells being large or CD30 positive. And it tends to retain CD3 when most other anaplastic large cell lymphomas do not. So I've got 2 or 3 others and then I will stop. This is a nice little almost spot diagnosis of primary cutaneous CD4 positive small/medium T-cell lymphoproliferative disorder. Quite a mouthful. This is nice because it has a really good prognosis, and if you get it right, the patient is probably cured. It occurs as a solitary nodule on the head and neck, and it's got CD4 T cells in it, which is small or medium in size, as you can see here. It's often got this nodular architecture, by the way. The T cells are CD30 negative. There are often lots of B cells mixed in with them, and sometimes in the past, I've seen cases that have been misdiagnosed as cutaneous marginal zone lymphoma, which then got reclassified later on. It doesn't have most of the mark, or doesn't have CD10, but it does have other markers of follicular helper T cells like PD1. Basically, if you excise it or give the patient radiotherapy or intralesional steroids, it gets better and it virtually never recurs. So that's something that's good news. Similarly, there's a CD8 positive version, which also tends to occur in similar regions, ear, nose, but also hands and feet. When this was initially described, people wondered whether mobile phone usage contributed to it occurring, I think because it occurred on the ears, but there's no evidence for that at all. These T cells are positive for CD3 and CD8, but also not for CD30. They've got some cytotoxic molecules like TIA1, but not all of them. And I think the most interesting thing is they have a dot-like positivity with CD68. I can't work out which of the CD68 antibodies does that from the WHO classification, but it's worth knowing, and at some point I must get around to checking, so sorry about that. This goes into complete remission usually after either surgical excision or radiotherapy, so another one that's really good news and important to recognise. So that's a classification of cutaneous T-cell lymphomas. Most of them, as you can see, are CD4 positive. I've talked about mycosis fungoides. If it becomes blood involving, it's called Sézary syndrome. And I've talked about the primary cutaneous CD4 positive T-cell lymphoproliferative disorder and the various CD30 positive disorders. It's worth remembering that systemic lymphomas can involve the skin, including angioimmunoblastic, peripheral T-cell lymphoma, and ATLL. Under the CD8s, I'm just about to show you this last one, subcutaneous paniculitis-like T-cell lymphoma, because once you see it, you'll never forget it. We've just talked about this indolent one, primary cutaneous acral CD8 positive T-cell lymphoproliferative disorder. And it's worth remembering that the extranodal NK T-cell lymphoma of nasal type can sometimes involve the skin. If you're not sure about a cutaneous lymphoma, if there's any way of referring to a more experienced colleague, it's worth doing that, because getting the right classification can substantially affect the treatment. But if not, get more clinical history, work out what the radiology shows if the patient's had any, or even the clinical examination. Is this lymphoma everywhere or just in the skin? And if you can do PCR-based clinality studies, if you need them, do. But I recognise that's not available everywhere. So I'm just going to show you as a last thing for you all to remember the subcutaneous paniculitis-like T-cell lymphoma. It's very rare, but it has an awful prognosis, and it causes inflammation and necrosis in subcutaneous fat. The critical thing you see is rims of rather strange-looking small lymphocytes around fat cells, and that's a really good example here, here, and here. There are very few other things that do that. These are CD8 positive T cells with a full complement of cytotoxic molecules and normally no differentiation towards NK cells and no EBV positivity. It's the rims that they form around the adipocytes that are absolutely pathognomonic. The main differential is lupus paniculitis, but the T cells in lupus are not atypical in the same way. They're not clonal if you can do T cell clonality, and they are predominantly, that should say CD4, not CD8. No, that's right. So they're not CD8. That is correct. So they're not CD8 positive. So here we are, subcutaneous paniculitis-like T-cell lymphoma with a CD8 positive T cells rimming the adipocytes, not CD4. The CD4 here doesn't have the rimming T cells. Although there are CD4 positive T cells mixed in, the ones that are around the rim of the adipocytes are CD8 positive. Whereas in lupus, you can see there are some CD8 positive cells, but the vast majority of cells present are actually CD4 positive. But of course, if you do clonality, the lupus panniculitis is not going to be clonal for T cells. So that's it from me. If you've got any questions or you want to discuss the thing, I'm very open to doing that. I don't know how the platform works. And if anybody is interested in some antibodies for looking at T-cell lymphomas as a surrogate to the PCR-based clonality, do email and let's see what we can do. Thank you very much.
Thank you very much, Liz, for that absolutely excellent talk, of course. And I recognise that last slide that you had from previous talks you've given. I mean, I'm not just saying this, that was an absolutely stellar talk on T-cell lymphomas. They are complex, difficult to understand. That was probably the best kind of lecture I've ever heard on them. So the delegates will have access to this by email to the recording, so I think it'll be very useful. The way you went through everything from the basic science through to kind of a really practical and pragmatic classification with lots of examples and many, not just anecdotes, but tips from your own practice has been enormously helpful. And I've certainly learned an awful lot from that. In terms, and also just to reiterate to the entire audience, the email there for Liz is up. It was up in the in the lecture. Please reach out to her if anyone wants to trial those antibodies. I think that the use of those antibodies is going to be absolutely key in our understanding and diagnosis and treatment of T-cell lymphomas, because it's really going to revolutionize that field. Because otherwise they're very difficult, and the clonality studies obviously are difficult to do and have their own problems. I've got a couple of questions around that, please, Liz, myself, and then I'll pass over to the audience without taking too much of everyone's time. So the clonality, the kind of like oligoclonal and aberrant false positive clonality that you can see with the T-cell receptor, so with the PCR studies, I guess with the antibodies, you can kind of overcome that because you'll see it in little patches. Is that correct or not?
I think that's a really good question. I think the reason we see oligoclonality, certainly speaking from work we've done in celiac disease, is actually because you've got a lot of similar T-cell receptors that recognize a similar antigen, but they're not the same. Okay. So you might see a mixture of TCR beta 1 and 2 among those. And that actually is a good question and something we need to look at. I'll write that down when we're finished. Because it's a good research question for my team, and I'm looking for a few projects for students, so that's a good idea. In terms of what was the second bit? Was it just about
that was it? So yeah. So if you've got a skin biopsy and the PCR would show maybe a clonal result from a small area of it, I guess if you're using your antibodies, they will just light up in one area of that, and you'll be able to see that it's just a small clone rather than the whole thing.
But again, I think the problem with the clonality is you're only looking at the length.
Yeah.
So you don't even know that they're all identical T-cell receptors, and often they aren't.
Okay.
So, and I think the other thing is sometimes just very few of the TCRs amplify if your DNA sample is not very good. So I don't know the answer to that. It's a really good question and going to be the subject of a lot of further work if we can afford it.
Sorry for that. So also in terms of the kappa and lambdas are really good when you've got plasma cells, but sometimes just demonstrating kappa and lambda clonality in a B cell lymphoma that is not highly expressing can be quite difficult, and you might not see it. But is it the same with the T cells or your antibodies? If there is a T-cell lymphoma, it will identify it, and it's not just differential levels of expression.
I think having looked through quite a lot of lymphomas, I would say that probably 2/3 to 3/4 of the time you might well be able to make a definitive diagnosis. The major problem is actually the fact that while you've got a clonal population that might be TCR beta 1 restricted, you might have a lot of tumor infiltrating lymphocytes that just confuse the picture. And at the end of the day, if you're going to give toxic chemotherapy, you have to be sure.
Yeah. So over to the audience. I'm sorry I, stepped in there. Are there any questions from the audience? We are over the hour, so maybe people have other things to go to, but for which I apologise. Any questions from the audience? We have a lot of thanks for you.
Great. Well, thank you very much. I've thoroughly
Okay,
enjoyed
thank you very much. And I can just say to everyone, thank you very much. Again, it will be heme again next week. It will be me. The interval act. I will be doing Trefines, but those who are keen hematopathologists can join next week, and the week after, it will be Angeles Monteros Fernandez from Liverpool on lung pathology. Thank you very much to Liz. Thank you very much to Diagnexia and Ava for their continued support of the programme. And thank you everyone for your attendance wherever you are in the world. Just remind those of you in the UK or anyone in that kind of territory, our clocks do change, so it will go to 2 p.m. for yourselves next week. But everyone in Africa and the rest of the world, it remained the same time. Our time changes, your time does not change. At the same time next Wednesday for all of you, and Ava will send out all the links as she always very dutifully does every week. Thank you very much, and as I always say, good morning, good evening, good night to everyone on the call. Thank you.